and welcome. Welcome to Fracture Files, the silver linings of geriatric fracture care. My name is Megan Sorich. I am a geriatric orthopedic surgeon, and I just love taking care of our senior population that falls. With us today is Dr. Carmen Quatman.
Hi, I'm Carmen Quatman. I'm also an orthopedic traumatologist who focuses on geriatric care, and very excited to help enlighten people about this topic and other topics that pertain to the patients we love to care for.
So Carmen, how did you first get interested in geriatric orthopedics?
I think it started in about my second year of residency. I was really interested in pediatric orthopedics at first. I really enjoyed the fact that patients had caregivers, and that we had to bring the whole family along as part of the journey. And during residency, I realized same thing happens on the other end of the spectrum for aging. But the difference is we just didn't have the same type of resources in place. We really didn't know very much. So around my second year of residency, I started seeking out opportunities to learn more about geriatrics, and helped establish one of the first geriatric orthopedic specialists. So Megan, how about you?
Yeah, so I really thought I was going to go into sports medicine. And then I feel like that changed throughout the course of all of residency. So I feel like my first and second years, I really liked sports medicine. And then I realized I didn't really care where the ACL tunnel was placed. So then I really liked shoulder elbow surgery and matched for fellowship in that. But then during my chief year, I realized we take care of more hip fractures than really any other injury, but at the same time, they have the least resources available to them. And just was one of those things in the middle of the OR. I was like, I really wish there was a fellowship for geriatrics. And sure enough, the attending that was with me was like, actually, there's one in Minnesota. And so they connected me with Dr. Julie Schweitzer and you, and kind of the rest is history.
Yeah, I think those are great points. And I think what was most interesting to me as I really started to learn was that we have a really big obligation to patients to help them make important decisions. And we aren't really given that opportunity, at least in orthopedics, to really learn about hospice type care and palliative type things that are available, so that we can help people make the best quality of life decisions across their whole age span. And so one of the things I loved most about getting that training was that, unlike many orthopedists, I got a lot of opportunity to see what are some really important hospice and palliative care conversations, and what should we really be thinking about when we counsel our patients about decisions when surgery is appropriate or not, and if we're making the decisions that they want.
Totally agree. And I think another thing that I learned are the resources that come with hospice and really other opportunities that, as you said, as an orthopedic surgeon, we're not really taught that, we're not really exposed to in residency. And I feel like our geriatric medicine friends kind of already learned those things. So I kind of felt really pleased with the opportunity that I feel like having that multidisciplinary approach and learning a lot of that stuff. I totally agree.
Yeah, what do you think you learned most when doing some palliative experiences?
So I think two experiences stand out the most during that year. One was hanging out with the palliative care team and listening to the way they present those difficult patients, talking to them about end of life care, these sentinel events, and using kind of almost emulating their words and being exposed to that, because that was nothing that I was exposed to. But my second favorite thing was hanging out with some of the geriatric physical therapists and learning osteoporosis, physical therapy, and working on trust falls with patients, learning how to fall and how to get up off the ground. And that was probably my two favorite opportunities of that year. How about yourself?
Yeah, I think there was a saying that really resonated with me when I was on doing the hospice part of it, and palliative, which was the person at the time mentioned our motto is hope for the best, plan for the rest. And I remember thinking, really hard about that concept, about how these conversations about what we choose near the end of life can be so difficult, and especially because people just don't want to think about it. And it's something that really resonated with me at the time. And then I was so powerfully able to take it later on. My dad was diagnosed with glioblastoma in early 2020. And it really was something that I kept in the back of my mind. We knew it was a terminal illness. We knew that he probably didn't have much time. And this was kind of overlapping with this time of chaos in a global pandemic for me. And we really focused on this, hope for the best, but acknowledging that we knew we didn't have a lot of time. And so we were able to plan accordingly when his mental status was still able to communicate with us all of the goals that he had. We had a really focused conversation and recorded it, and we were able to lean on that at the times when we didn't have that ability to have that conversation anymore. And it was a really powerful moment for me to recognize that I was able to carry that skill set into my own personal life. The second thing I really enjoyed was going out to the skilled nursing facilities. I think I learned one of the things I think many healthcare workers who don't get the opportunity to work out in skilled nursing facilities is we assume that they are getting medical level care. And I was fascinated to learn that it's actually more of just an environment where they have people who can help make sure meals are maintained, and potentially getting to and from physical therapy and things like that, making sure they get medication delivered on time. But you're not getting medical level care per se. And so that assumption that you're getting hospital level medical focused care is something that many people assume. And when they end up at the nursing facility for some reason or another, are kind of surprised to find out that that's not what goes on. And so it was a really eye-opening experience for me to figure out how we can make that transition safer, and to really understand what goes on in that environment so that we can help prepare patients and their family members for the appropriate experience.
That's a really good point about skilled nursing facilities, because I feel like a lot of the perception is not only hospital level care, but a lot of rehab, because they call it a rehab facility. In reality, sometimes they're getting physical therapy, maybe an hour a day, if that. It's truly like a nursing home environment with some medical care. Again, nutrition is emphasized, but you're totally right. I think that was a really great eye-opening experience.
Yeah. And another thing that really stuck about for me was getting to meet Dr. Bob Kane. I'm not sure if you got a chance to meet him, but he
Yeah.
was quite an inspirational character is the only way I can describe him. He really had written many of the early works on geriatric syndromes, and really trying to understand academically the type of environment that at the later stages in life that we don't really think about until we have to deal with it. And it was a really good experience to see how we can better prepare ourselves, our parents, our healthcare system for the things to come. And we often just don't go there because it's either embarrassing when you talk about incontinence or falling, or things that really are uncomfortable conversations in a healthcare setting. How important it is that we normalize it, and how we educate about it, and we just break down the barriers to making it feel uncomfortable. And so he was a real inspiration for me too, in my fellowship.
I think it's really interesting that you say that, because I feel like it kind of goes back to talking about geriatrics, or even aging in general. I feel like our society as a whole is anti-aging. Those are the commercials you see on TV with anti-aging skincare and all that kind of stuff. So you're right. We don't talk about a lot of incontinence, difficult conversations, because people don't want to think that it's ever going to happen to them. But I feel like with some education and really embracing aging, because aging is fantastic. You're getting wiser. As I usually tell my patients, you're not getting older, you're getting wiser. By embracing that and really awarding that, because being old is awesome, right? What's the alternative? Like maybe we could change that in our society.
Mm-hmm. Yeah, I think even around the time, I find it hard to write papers and even sometimes do lectures, because people don't like the word geriatrics per se. There's kind of this, tell me when geriatrics applies to me. And the truth is that, I mean, we apply it to 40-year-olds for maternal fetal medicine,
I was just gonna
geriatric
say that.
pregnancies.
You're right. You're right.
And I don't know how to frame it more positively. You know, some people don't like the word elderly. Some people don't like the word,
There
it
isn't a
doesn't
good
necessarily match what they feel. And I totally agree. And sometimes I try to explain geriatrics from the perspective of the value that a geriatrician can bring differently than maybe your standard internal medicine perspective, and the idea of focusing on quality of life, and maybe acknowledging that everybody's body responds differently in terms of blood pressure medication and diabetic medications, and sometimes over treating when our body is not in the same stage of reactivity that it was maybe in our 40s can really change how you feel as you navigate your life. And so I really appreciated the perspective that geriatric teachings brought to the table, which was really enlightening. I still remember, I'm not sure if you got to work with Dr. Terry McCarthy, but she handed me a
She
pill
was my
box.
favorite. I loved her.
She handed me a pill box with a bunch of candy in it and a little sheet about how to take your medication, quote unquote, appropriately. And it was a test that she kind of gave to residents and trainees that she worked with to really help people understand what we ask of our patients. And it was fascinating. It was things like, you have to take this after breakfast, but on an empty, 30 minutes after, or you must take this pill on an empty stomach, and you have to take this one with food, and just like this basic compliance list. And then you had to mark every time you were able to achieve what was asked of you. And this exercise and empathy training was something that has totally sat with me even now, as someone who, doesn't have to take a lot of medication, who doesn't, I have a very, I wouldn't say scheduled life, but as a surgeon, my schedule might change a little bit. But just to be able to be compliant was tough. So I can't imagine somebody who has vision difficulty or some memory deficits, or even some arthritis deficits for filling the pillbox. And so it just was a really amazing exercise to recognize what we ask of our patients, and then assume that they're able to be able to fulfill that is just, they don't match all the time. So that was a really cool.
You're absolutely right. Yeah,
Story.
it's amazing.
Yeah.
She was so fun to work with. I really appreciated that time that I was able to spend with her. It was really fun because a lot of the patients that we saw at Methodist, then we saw with her in the SNF. So it was a lot of continuity of care, which was a lot of fun.
Yeah. Yeah, there was one other one that really stuck out with me that year, which was, there was a patient that was repeatedly coming back to the nursing facility. They would do amazing when they were at the nursing facility, and when they would get ready to discharge them, they thought they would be already, and then they'd see him back within a week or so. And during one episode, it was determined that the spouse was filling their medication box, and that spouse had memory issues.
Oh
And
no.
so they were taking extra blood pressure medications, which was causing them to bottom out. They would pass out, and then they'd end up in the nursing in the hospital, and then kind of just repeat the cycle in the scenario. And it was just, to me, I realized how we rely on our patients to be able to execute, and even the support system around them may not be able to help them the way that we assume that it can. And I think that those principles that I learned in that geriatric perspective, we really need to do a better job of highlighting it for more interdisciplinary experiences. It doesn't matter what specialty we choose. These patients are part of our specialty, unless you choose a true pediatric experience,
Right.
you really do have a geriatric practice in many ways. And so we have an aging population. We have a healthcare system that really hasn't kept up. We have amazing technology out there that's really able to help us fill the gap, but we haven't really adapted strategies to make sure that we set people up to fill the gap. It doesn't matter how great your technology is if people don't know how to use it, or they're not adopting it, or it's too complex. And so we really have our work cut out for us in healthcare to make sure that we bridge that gap and make sure that people can excel even in their later stages of life.
Definitely. Your patient example reminds me of a guy that I treated recently. He's in his probably mid 90s, and he lives with his wife who is has some confusion, and his daughter always comes to the office visit. He's very, very thin, and we talk about nutrition. And his daughter always says, you know, they've fed the dog probably 10 times each day, but they forget to eat themselves.
Yeah, yeah. Sometimes caring for the pets better than we care for ourselves is
Exactly.
definitely a real issue. Hey, Megan, I would love to flip it on its head and ask you, what did you learn from the orthopedic perspective during your geriatric fellowship time?
You know, I really enjoyed working with Dr. Schweitzer, Dr. Marston, and especially Dr. Cole. I feel like they had great opportunities for complex fracture care, especially working with Dr. Marston. He did awesome work with periprosthetics, and I take care of a lot of that in my practice now. And a lot of conversations between retaining the hip implant, if it needs a revision, if it needs to be fixed, and taking those complex kind of patients and helping them walk. I feel like in my residency, there's a lot of times that we would fix some of these fractures, and even in the elderly, we wouldn't let them walk. But that really changed my perspective in fellowship, that you need to trust your fixation when you leave the OR because everybody needs to walk. And I really appreciated having those mentors kind of teach me that. How
Yeah,
about
I think
yourself?
yeah, I think that's an excellent point that, the highlight of we talk about quality of life a lot, but mobility is such a major part of quality of life. So if you can't figure out how to navigate your environment with a gait aid or even a wheelchair, or how to feel somewhat independent, it can be a real challenge for quality of life. And when we limit someone and they get weaker each day by their ability to mobilize, that deficit can be harder and harder to overcome each decade in life. And so I think that's a critical skill that I learned too, is this idea of make sure you can trust your fixation. I still also, one of the things that's really hard to emphasize to people is we have a lot of techniques out there radiologically to look at bone density. But what we lack is sometimes someone can have decent bone density, but the quality of bone just isn't very good. So I just remember even getting to feel the difference of what different types of bone quality can feel like. So if you're drilling on a young person, it's a lot like drilling into hard bone. And when you're drilling into someone who has osteoporosis or a nutrition deficit, I almost liken it to like trying to drill through an egg. Or in some cases, it felt like mashed potatoes, and they could
Mashed
feel very
potatoes.
different. Like you would
Yeah.
kind of take a drill and you would put it into this eggshell and you just kind of feel it cracking behind you, versus sometimes it really just feels like mashed potato or soap and you're just trying to pull bone together. And I think, to me, practicing medicine for someone on the later age spectrum just feels so significantly different. Their ability to heal is different, their skin and soft tissue is different, and all of those principles, while we might talk a little bit about it in our residency training, I would say the last 7 years of my practice have been the area of my focus, is how much better can I fix this poor quality of bone, or how am I going to protect their soft tissue so that my fixation, while I know I can trust it, that their skin is going to heal over it, or that even if they don't heal, that I can avoid an infection or things like that. So while I felt like I really learned the surgical ideas and concepts and got to practice feeling the different types of bone quality, I love your idea, like to define periprosthetic. That's where someone has a fracture around a total joint or a total hip or some type of implant. It's almost like a self-created perpetual problem, right? So we put hard something next to soft something, it's going to break. And so these concepts we can help someone mobilize better with their total knee or total hip, but we now have created new problems that are getting harder and harder to fix, because when you lose bone, there's just really difficult to capture good fixation. So I would definitely say the last few years of my practice, continually having to see it more and more complex and adapt techniques, has been the biggest challenge and also the most creative time of my life.
Definitely. Yeah. And it surprises me even at like working at a major medical center, we don't talk about nutrition. So with skin and soft tissue and healing and wound healing and bone healing, I kind of feel like before I started my job here, we didn't talk about nutrition and the quality of nutrition and getting nutrition dietetics on board with these patients to provide every resource available to heal.
Mhm. Yeah, absolutely. It's so critical and just really hard because we really only see patients for 4 or 5 days in the hospital.
Yeah.
What we can give them in that moment really is difficult. And so it's really important that we build these strategies for connecting our healthcare sectors rather than just these incidental, moments of care that we have in hospital settings. Well, Megan, this was great. I'm hoping that we can generate an audience that really wants to hear more of
Yes.
ways to best treat our patients in this category of patients.
Yeah, thank you so much for your time, and we will hopefully reconnect next time.
That sounds great. Thanks, everyone.
Thank you.